Hi everyone, my name is Martijn. Welcome to what is already the fourth episode of our Let's Talk Oral Health webinar series. We've got a very cool discussion coming up today, so let's jump straight into it. I will introduce the speakers first now, but in the meantime, just let us know where you're from, and as always, don't forget to give this video a like. If you're watching on Eventbrite, small tip, click on the Go to YouTube button on the left bottom corner of your video. In that way, you can interact with the speakers, give feedback, and of course, ask questions. So today we're talking about home-based oral care from the perspective of clinicians who treat a very unique and challenging group of patients, those with special needs. And to do so, we have found two very experienced experts to help us out. Let's start with the first speaker, as I am joined by Miss Anna Louise Tolan from Mississauga, Ontario, Canada. I hope I pronounced it correctly. Anna Louise is a practicing dental hygienist. She's an educator and lecturer who has 37 years of clinical expertise, specializing in periodontal and implant therapy and person-centered care. She also has more than 2 decades of experience facilitating lectures and hands-on learning. And interestingly for today, for the past 17 years, she has been working in a practice setting, specializing in patients with special needs. Hello, Anna Louise. How are you doing?
I am great. Thank you so much for having me. This is a great topic that we're going to enjoy today.
So, what brings you to special needs dentistry? Why are you so passionate about this topic?
Well, mostly because I have a nephew who is autistic and is requires special care, and then I after working 18 years in perio, I found that there was a whole nother group of medically compromised patients that I really wanted to learn more about how to manage them medically and take my education from perio and do the utmost for them.
Mm-hmm. Yeah, that sounds superb, and I think we can learn so much from your experience today. I think we can move on to the next speaker, and I'd like to welcome Dr. Mohit Kothari from Aarhus, Denmark. I hope I pronounced it correctly as well. Mohit earned his PhD degree in oral rehabilitation in 2013 and his master's in dysphagia in 2021. He's currently appointed as associate professor at Aarhus University. Mohit is a clinical consultant for the management of dysphagia and oral health in patients with brain injury. And as a principal investigator, Mohit is currently developing an oral health assessment and treatment plan tool for hospitalized patients. It's a mouthful, Mohit. How are you?
All good, thank you. Good morning to everyone.
Perfect. Good. Yeah. Good morning. It's evening for you, and it's morning for Anna Louise. So yeah, we're really global today. Same question to you, Mohit. What brings you to special needs dentistry? Why are you so involved in this?
Well, that's a very fascinating topic actually. When I was doing my undergraduation as a dentist, we never thought about moving away from the normal patients. But as soon as I finished my PhD and then I moved to a neuro rehab center, there I found a lot of diverse phenotypic population, and then you can see that okay, dentist is not just about the oral cavity.
Mm-hmm.
It is linked with so many things, and then you just don't treat the patient as a tooth or as a single entity. But there are so many complex things that are involved together, and we need to see that as a total, in total phenomena, and that is what fascinates actually. So it's all about connecting the dots with different multidisciplines and interdisciplinary approach, and this is how it makes it more fascinating actually. So you
It
don't
is.
have all the knowledge, but all the knowledge comes together that it makes more better.
It
That is
is
the
really
whole.
fascinating, absolutely, and I think your experience in the university can really help us today understanding this important topic. Talking about which, let's just start today with this topic of special needs, and I think it would be good to begin with setting the stage by trying to define what we actually mean by special needs. Can we sort of segment patients into certain categories so that we can tailor our treatment plans? Mohit, I think you have some ideas about this, right?
Yeah, to be very specific, the specialty dentist is a very broad topic, as we already discussed
Yeah.
about it, and then it's very difficult to categorize in a particular box. But broadly, what we can do is that we can really categorize these patients' populations or the phenotypes in a broad two ways. One is the elderly populations in our community with our parents and our guardians, and our in our family settings also. We see a lot of elderly populations. They are otherwise healthy, but the aging process is letting them down. The physical limitations, the psychosocial limitations, and this all actually kind of hinders to their normal everyday activity. So it's not only about the oral cavity, but all as a general as well. So these all small things, that aging phenomena, it really delays all the physical and weakness actually. So that's a one category which is elderly but otherwise healthy. But there's another a big category which is elderly but they are having some kind of a comorbidities. And when I say comorbidities, because the we are in the age of 60s and 70s, and then we catch up with cardiovascular disorders like stroke and brain injury, or sometimes diabetes and all. So these individuals requires more special attention. Their motor activities are going down, their cognition is going a little bit down, so they really need a support. And this support not only means that in the hospital care there's a professional, but when they're back home also, they need a support from their spouses or guardians. And everyone is there for support, but these support should come with more scientific evidence. They should know what to be done. For me, I would like to help my parents, but if I don't know how to help them, that's a big task as well. So there's a lot of hindrance. So it's all about giving them the right knowledge which can be transferred translationally to the patient's need actually. So this is how we can broadly divide the patient population over here.
Yeah. Yeah, I think that's a good segmentation. And Louise, I mean, I've already mentioned it during your introduction. You have 17 years experience of working with, patients with special needs. Can you find yourself agreeing with this type of segmentation? What type of patients do you typically see in your practice?
Well, in my practice, it's a real mix between community dwelling type of client or the type of patient that's living at home. So a lot of them we start seeing because they bring their family member that has special needs, or perhaps a community dwelling. I might already see several people that live in that community dwelling. And then we also have family members that have people in palliative situations, nursing homes, and we see them, through their process of life, right? We might attract some of these particular patients because of our special facilities. We have wider hallways, bigger rooms. I can actually have the type of wheelchair that will actually recline, and I can work with the patient right in their regular wheelchair, which is so much more comfortable for them. It's not so cumbersome to have a transfer, all that type of thing. So we've accommodated a lot of areas in our practice to allow patients to come in even on a stretcher if that's required, and so we see them in a lot of ways, and so this requires a lot of advanced thinking, logistics, trying to be really ready for when these people arrive, because many of them come with many caregivers, right? And so we have to accommodate a larger number of people and their gear. Sometimes they're coming on oxygen, different ways they show up to the practice, and then because of that, we continue to grow and make oral health care plans that entitle them to have more time spent on oral care, which is really what our focus is in this particular situation. We had these clients with, as Mohit was saying, with these comorbidities, and we need to be able to address them effectively. And taking the time to create an oral health care plan, which would allow the caregivers more specific direction and more specific time to work with a patient, is the whole idea that we need to embrace.
Mm-hmm. How exactly does such an oral health care plan work? I don't think we are really familiar, for example, in Europe with this concept. How would you explain how it works Is it like a prescription?
It is. It is. It's exactly like that. So when someone is in a community dwelling or in a, say, like resident nursing facility in Canada, people have a certain amount of time that is allotted for personal care for that particular individual. And if we find that they require more care, say more than 15 minutes, which for personal care, that encompasses their oral care. Well, we know that someone who has MS is going to require way more time to have someone support them initially to provide themselves care and later on for someone to provide the care. So we need to make these oral health care plans, which then describes exactly the type of service that needs to be accomplished by either the patient or by the caregiver. And it implements a wide range of descriptive processes that need to happen for that client to keep their care, their oral health elevated so that it's not impacting their overall health. So I might write down that that this client needs perhaps initially supervised coaching for brushing 2 times daily with a specific kind of toothpaste catered to their need. And what that does is then it allows that family to advocate for that particular individual to have more time spent. So I estimate how long that's going to take for someone to do. And then that becomes exterior to that initial self-care like that is provided. So I get additional minutes for that particular individual. So if I need someone to supervise them twice a day for 15 minutes, then that's half an hour that's spent just on oral health, which is wonderful.
That's fantastic. Yeah.
Yeah. So in that prescriptive type of description, you would write down exactly what needs to be done, what type of either aids, products would be recommended to be used, and that provides the person-centered approach, which will help the patient the best.
I think it's fantastic. I think you, apart from you have the time to set an entire treatment plan with the patient. That of course requires your time as well. So basically, it's a way of also providing a financial incentive. Buying your time to give them instructions. I think it's a fantastic way. Mohit, are you familiar with something like this? Do we have something similar in European countries, by your knowledge, or?
Well, I would say yes and no in both directions. The reasons is that the oral healthcare plan, which is quite familiar in a normal private clinics, but when you go to the hospital, in the hospital you have patients with a different phenotypic populations, and these phenotypic populations sometimes is because associated with the cognition issues, sometimes with a motor impairment. So we kind of made a tailor-made plan. And when I say tailor-made plan, it's because the reason is that everyone has a different necessity. So Anna has completely put forward in a right direction that we make an individual plan actually. And that is very important for us as well. A lot of my patients actually, they are brain injured. They cannot get up from the bed, forget about coming to the dental chair. So we, as a clinician, has to go to the bed and give most of the oral hygiene maintenance or oral care plan on the bed. And even once they are home, they are physically not fit, they are cognitively not fit. So there's a lot of supervision going on from one plate to another plate actually. Just imagine, for example, we have a Parkinson patients in our hospital. These patients are just not only physically disabled, but they are also cognitively disabled. They have a lot of dexterity issues also. So if you give any normal Parkinson patient to eat a food, so he just cannot hold his hands because of a lot of dexterity issues. So nowadays, a lot of research has been done in that area that, okay, you have a toothbrush with a heavy grip, which can hold the whole fist together, and which is so heavy that the patient can stabilize his hand actually, and then he can make a small movements in the hand with a supervision or without supervisions. So there has been a lot of advances that is happening over here. And a lot of people also mistakes that this pediatric toothbrush. I would say for our special care dentistry, the terminology that we use for our patient population, always go with with a small head toothbrush, always go with a soft bristle one. And the main reason is that these patients are just not normal. They need special attention. And when I say special attention, this big bristles or the long head can give a lot of oral trauma actually. So it's good to be safe. Use the soft toothbrush bristles, use the small heads over there, and then use a circular motion. And always these patients require some kind of a supervision actually.
Yeah.
So in my terms, I would say that there is some kind of oral healthcare plan, but there is not a validated oral healthcare plan where my role comes into the picture, that I'm making a validated oral healthcare plan. As you know, this dentist and dental hygienist, it's I'm a dentist, but I can see that there's a lot of need in the hospital. But due to the state burden of the finances, you cannot put dentists in each ward or in each hospital. So you have to train the nurses, because oral care is a kind of fundamental activity for the nurses. They are the first person, the first professionals. They come in touch with the patients. So they know the patients from the day one. So if you kind of develop a oral care tool for them, which can be easily delivered, it can be a good financial model for the state as well, and maybe a good oral healthcare model for the patients as well.
Yeah.
But still we are working on that, and we are just halfway. So we have done a lot of diagnostic studies, but we still want to go on the treatment plan, and let's see how it goes. But this is how you know the research works. It takes a lot of time
It
to
is.
find the right evidence.
It does. And you're talking about patients relying on hospitalization, but how about those patients who rely on home care?
Yeah.
Does that?
Yes. So what we do is that we have segmented our patients, as I said you before also, that now in the hospital you have the professionals where they can take care of you in many ways. But when you go back to the community, you don't have that professional experience anymore. So what we have done, we have made a lot of kind of a charts and plan depending on the individual patient's need. And we always educate the spouses or the guardians how to take care, how to supervise at home. And it's just not only brushing the teeth, because people think, what is oral care? Oral care is just about brushing. No, it's far beyond that, and specifically in our special dentistry population actually. So the small tips what we give to them is that, because it's easy to remember, is 2 square formula. For example, you brush twice a day, 2 minutes.
Yeah.
If put an alarm over there, and then you get used to it, because this 2 square formula, I've seen in the research, it works very well with the pediatric population actually. Because when we are growing up, we just want to brush fast and just move out of the bathroom. But this small 2 square, if you just say to them 2 square formula, they always keep in the mind. And this is the same way it works with the special care dentistry population as well. And it has given a wonders actually.
Yeah.
And we have done a lot of kind of an educational material for the spouses. And when I say educational material, it has to be interesting. The reason why I say interesting is that you put the pictorial diagrams over there, because sometimes you can give a lot of knowledge, but how the knowledge is transferred is more important over here. And those pictorial diagrams really help them to understand what am I and what I'm supposed to do, and how should I take care of my relative basically.
Absolutely.
Yeah.
Fascinating. Great stuff. I see we have already a question from the audience. Let me put it up. It's from Francine. It's directed to you, Anna-Louise. Do you occasionally get asked to go and see a patient in a hospital setting, or do you only treat patients in your own clinic?
I do get asked to go and see patients in the hospital setting, as well as in nursing homes, and I do go and see those particular people. They're usually people that I've already been treating, and now there's a further process of disease that has happened, and they're in some form of discomfort or so on. And yes, I've packed up my stuff and taken it with me, and all my little tricks and medicaments, and see if I can help them out. These families, they're aching for this type of support, and we're trying to provide that care. Once they have experienced them feeling better, or that area not being sore, they don't want to put up with that, right? And often there begins to be a lack of communication between the patient and the caregivers because of deterioration and just a lack of speaking, or they just accept that pain is going to be the norm, or uncomfortableness. For example, when they start to load up the medications and they're suffering oral dryness and they're so dry that everything they eat is burning. And so being aware as these unfortunate situations unfold, and being able to talk to family members. And I often get calls just clarifying, okay, so this isn't working. What's our next step? So, baking soda and water is your biggest friend when we have mouth sores. And especially right now when the fruit and vegetables are more acidic, when anything's in season, right? That increases. And with those with oral dryness, they may come in and they may even present where they're having a tough time even talking because of such a lack of saliva. And that tends to also go through their whole body, but they might also be able to articulate that their eyes are also dry. So I'll also bring that to their attention. Are your eyes feeling dry as well? And then that allows me to then engage the family that this also is another need. So it's about looking at whole wellness and trying to keep them as well as possible for as long as possible, and trying to decide what is like the functional part that they need help with and what is the psychological part that they need help with, right? Because we all have seen during COVID how people's deteriorated mental health created a huge deterioration of oral and self-care, because people just stopped caring, right?
Absolutely.
So,
Absolutely. I mean, Mohit just mentioned already the role of spouses or guardians, being part of the oral care plans that he talked about. Does that also are those also included in your oral healthcare plans? The role of the guardian or the spouse or the caregiver, are they also included in this package that you talked about, Anne-Louise?
absolutely, because quite often my clients have caregivers. So sometimes I explain to them about coaching. I'm going to give some examples later on, but one of the things that I do with more capable adults that are more higher functioning is when they're missing in a certain spot or they're having difficulty brushing, is we take pictures of them with their brush in all of the right positions, and then we put them along their mirror in the bathroom so that they can sort of play match, right? And then that kind of gives them prompts to, I need to make sure that I'm hitting all these spots. And that has been very successful for me to get some of my, clients who want to remain independent, and they just need someone to coach them. I have a couple of others that live independently, some high functioning Down syndrome clients that I see, and they live independently, but one of them tends to forget to brush her teeth. And so I send her home with this huge Post-it that she puts on the back of the front door. So before she leaves to go out, it says, "Have I brushed my teeth today?"
Right.
So, it's like thinking outside the box to make it work, right?
Yeah.
And trying to address their needs in whatever support level that they have. So when the care worker goes in to check on these two gals that live independently, she knows that she needs to make sure that she's done at least one good brushing for the day. And so this is one of those coaching things. So I need the caregiver to help participate, as well as I give them a prompt to take home. But there's lots of different ways that we have to assess when someone has, even just someone who's dealing with an injury or a surgical aspect of, maybe they've had some type of accident and their hand was disfigured in some way, and now their dominant hand can't brush their teeth. How are we going to work towards improving that and choosing the right devices and making sure that the vibration isn't bothering them? All these things come into play,
Yeah.
you know.
Yeah.
So
it all sounds very obvious and straightforward, but it's you have to think of so many details. I think it's really great work and fascinating. We talked about different type of patients now with special needs. Maybe we can take a deeper dive into those actual special needs. What are the most common ones, and what are the challenges that come along with them? And I think to make it sort of comprehensible, people always like to cluster, create categories. And in this case, you often talk about functional versus psychosocial, like these two distinct clusters. Could you tell maybe a bit more about those two types of special needs?
Well, in the functional aspect, there are those that are that just can't brush their teeth, or even the caregiver has challenges brushing their teeth. So we try and thinking outside the box about how are we going to get that done, building in reward systems with stars maybe, or maybe getting someone to use like a munchie in order to stimulate tissues and create more saliva. And then we see others that need different types of apparatuses, as Mohit as so eloquently put, that are different types of clients will need to have accessory devices in order to hold things. The psychosocial part becomes a huge issue because that might also be on top of a functional issue. And I think that can be a huge limitation, and that's previous experiences, any type of fear with regard to any type of caregiving. It may or may not be dentally related. Certainly people feel that they're kind of get shameful about that they can't look after themselves. And really, we're not here to judge, we're here to help. So making sure that they understand that this is our point of view, being very empathetic. We're going to go through some of these things, and I think that understanding the origin of a previous experience or understanding their issue, I have found it's very, very helpful. We certainly want to utilize when there's a potential for poor communication. I love to use the show, tell, do type of a concept, because we need to remove that fear. I mean, the whole thing is to build trust, right? And in creating that trust, then we're trying to decrease the anxiety that they're going to have for the appointment. So if I take the time to show them, for example, on some of my lower functioning types of clients, taking the time like you would with an initial child's appointment of putting water in a cup and showing them how Mr. Slurpee works, or, in the saliva ejector, and showing them the different sounds and taking the time to figure out, okay, this sound is, tends to set them off, or what things are going to be setting them off. So if we show them some controls, and then we actually do it with them. This is one of my clients, and she is a functioning Down syndrome client who has had a previous experience, unfortunately, with some type of abuse. She only says yes and no to me. She can, explain to me what she likes and what she doesn't like, but not much of anything else. And she's only ever sat sideways in the chair. She will not sit properly in the chair, what we would consider to be properly. This is properly for her. And so early on, in order to make her feel that she had some control, I taught her how to use the saliva ejector within the cup and so on. So her job in the appointment is to operate the saliva ejector. And you can see there that she holds it and I do my work. It's pretty awkward and pretty tiring. And then she operates the saliva ejector, and we take moments where I squirt water in her mouth because she's quite dry, and I check and make sure that she's not pouching food. That's another thing that one of the things that we really need to monitor in some of our limited conversational type of clients, that we're seeing how they're doing, how are they coping with their food, and where is it sitting, and what type of problems are we having. So so here we have a picture with letting her have her turn to operate the saliva ejector, and as I pointed out, there is a backflow protection device on that saliva ejector that she is working for herself. So her and I worked together to complete her appointment. When I first met her, pretty much all of her teeth were mobile. I've now been seeing her for about 12 years, I guess. And early on, I got her to accept to wear a day guard. And so she wears a guard all the time. And now only 2 of her teeth are mobile. Everything else
Wow.
is, firmed up quite nicely. She has excessive wear, as you can imagine. That kind of goes along with the situation. But we have managed to preserve her dentition, and she's very happy to come and see me. But if the interval gets elongated, then that makes it a little bit more challenging, which we're going to kind of dive into in a little bit.
Yeah, that's fantastic. Please don't, for those who are watching, please don't take screenshots of this picture, these clinical pictures, of course, to preserve the patient's privacy. That's a fantastic example, and I really like this show, tell, do strategy. We moved subtly into fear, dental anxiety. Mohit, you also have some thoughts about dental anxiety, dental phobia, dental fear. Could you maybe share a bit of your experiences with this topic?
Yeah, exactly. Actually, this dental anxiety, it's not just a phenomena that's happening in a specific phenotypic population. We, as a kid, has grown with different kind of an experience with the dentist, and these bad experiences with in the past with the dentist is also has been deep rooted in your heart, and that sometimes creates a lot of dental anxiety. So that is a very incredibly common and can affect anyone actually. Forget about the specific phenotype population that they need special care needs and all like that. And there are many factors behind that. One is the dental setting actually, the environment that stresses out the fear of needle, for example, and the perceived lack of control. Okay, I feel myself I have to go to dentist, but I still have a lot of I don't have that much of courage to go and meet and see and do the things like that. So that also makes it a lot of uneasiness for a lot of patient population actually. And sometimes we self judge ourselves a lot. Okay, we missed our last dental appointment, but that does not mean that you have to miss the next one as well. So it's always a self judgment that okay, my teeth are bad, I'm not keeping proper care of that, there is a lot of malodor or the bad breath. So it's always a good idea when you start rather than just wait and wait until it gets really very bad into the shape and situation. But the common symptoms that what we see in this dental anxiety patients are that they might have a little bit of a high heartbeats. The heart beats a bit faster before the appointment starts and all like that. And they try to, kind of postpone their dental visits just because of this anxiety issue. And I think dental anxiety is quite a common thing which is happening in most of the population. But when it comes to dental phobia is a bit of a next step to the dental anxiety, which can be which can be a bit of a severe than dental anxiety. It's less common, but once it happens, it can really impact you at a larger instant. Actually, they completely avoids appointments until there's they experience a painful situation. For example, if I have a bad toothache, until then they will try to survive with the painkillers and all like that. Uh, and sometimes we see that this looks like to me a kind of a dental anxiety, but no, there's a difference over here. when we say dental anxiety, these are a very, very temporary bouts. But if you cannot have a sleep just because of thinking that, okay, I have a dental appointment tomorrow, now you're converting your anxiety to a phobia, actually. And this is very irrational, actually. They have a very hard time confronting and overcoming this, this panic attacks and then feelings that, okay, I cannot do anything. So there's a very distinction that we need to make them aware, make them educate, that even one or two bad incidents cannot be your long-term consequences, actually. So we have to accept the fact things has gone bad, but we need to have a regular and frequent dental appointments, and rather than getting orally sick, it's always good to have this continuing education and a talk with the patients, because this talks helps a lot. and and now coming to our specific phenotypic population, what I have seen in these patients are that they are not only physically sick, but they are also emotionally sick. Their cognition levels are quite low and quite down. They are already aged patients. The muscle weakness is already over there. So what we do is we also look on different items in a segmentation way. We just don't let the patients open the mouth, because the sensory stimulation plays a major role in this all kind of activities. In our patient population, what we have done is that we always start with the hand. We have a hand gesture, then we feel their hands, because sensory stimulation always starts from the hand first, and the patients can feel that hand touch is something soothing for me, and you can easily see the reaction on the patient's eyes, actually, how fearful or anxious they are. And never ever enter directly into the patient's mouth. That's a kind of a no in this kind of a patient population. So always start with the hand gesture, start feeling their hands, and that sensory stimulation helps a lot for them to get comfortable, and then slowly enter the mouth. So these are the small step-by-step processes, but it's very important. And what we do, that when we take the whole oral cavity, we divide into 7 different segments. The lip is very important part, because that's the part where you're going to start and move inside.
Yeah.
Our patient population have a sometimes a lot of a lip seal problem. They just cannot close the mouth. And that's a big issue, actually, because the saliva is drooling and all that. You might have seen a lot of pediatric patients, actually. The saliva is always drooling. And we also have a lot of epileptic patients in which you cannot control saliva. So sometimes what we think is that, oh, it's hypersalivation, but actually it's not hypersalivation. It's a normal salivation, but due to the improper lip seal, the saliva is just flowing out. So we need to find the real cause over here before giving any kind of a treatment plan. And the same things goes with this salivation also. A lot of patients are hyposalivating, having a xerostomia and all like that. So you need to treat with a particular segment just after knowing the cause.
Yeah.
So if xerostomia, go with oral moisturizers and all like that. So it all depends on what kind of issue you are having, rather than treating as a in total. That's why, as Anna also mentioned, we also believe in this tailor-made approach or an individualized plan, actually, because every individual is completely different from another, even though they have the same background. Then also it makes a lot of difference. Yeah.
I think what you mentioned with the hand gesture, the touch, I think that's a very nice segue into our next topic that we want to talk about, is senses and emotions, because it can be very overwhelming for this population to come to go to the dentist or to the dental hygienist. And senses and emotions are very important, I think, in this aspect. And I think you also had some ideas about this, Anna Louise, and some examples.
Yes, I think it's really important to appreciate that our senses give us so much information, and really, no matter whom we are, but for those who are most vulnerable, these senses are heightened, right? And so we need to make sure that we don't do things that may trigger some poor outcomes. It's so much easier to increase your awareness, so that then you have a more positive outcome. So, for example, let's just easily start with what they see when they come in. It's better to have things looking really tidy and very simplified, because too many things out can be overwhelming. and things that are familiar. You want to do some for some of these types of vulnerable clients. We want to do the same things in the same process every time so that they can count on it. And that way they feel like it's more controlled. Some of them may be light sensitive. They get headaches. They're prone to migraines, or they're just very sensitive to light. And so sometimes so for quite a few of my specialty clients, I work with no overhead lighting. I only use the illumination on my loops because that's all that's required. It's also really handy that I have illumination on my loops when I'm working from a wheelchair, because obviously I'm not centered over the chair, the traditional dental chair. And then it's other triggers that happen, like when a caregiver brings the patient too early and they're sitting around waiting, and that just causes them more anxiety. So making sure that they're very clear about how and when to arrive. I find the biggest challenges are those of my clients who we think are sort of under control, and then they get a new caregiver and it's like, oh boy, here we go again. We have to retrain them as to all the needs of these special clients. What does your office smell like? Does it smell like a dental office, or does it smell like cookies? One of the things that we do in our practice, believe it or not, is we cook cookies pretty much every day between at 10 o'clock, so that they're there and they're packaged individually. And as we know, we all need to have a reward when we've done something well. So when they leave, they get their cookie. Now, this is really advantageous for our clients who need those types of rewards. But we all need a reward, if we've done something that's caused us to be brave, and courageous, if that's what it takes to get you there. Pardon me. How things taste are also a concern for our clients. Excuse me.
No worries.
So knowing that the flavors that they like or don't like is super important. I think we need to know what's normal for them. So for a lot of these types of clients that I see, strong flavors are not appreciated. And those who are dealing with any type of oral dryness, same thing. So understanding what flavors and what tastes are sensitive to them. Also, what they hear is really important. Some don't like the sounds of things. I deal with one lady, as soon as she hears a high-speed handpiece, the tears start rolling. Now, obviously, this is from a previous experience, but it's really hard to pass that by. So it's taken us a number of years. So now she comes in with headphones on, playing her music, and I actually call her later about her feedback on her oral care and going through things, unless I show her something at the time fairly quickly, just to make this a non-issue. So, watching their favorite TV show or making sure they have music that is relaxing for them can be really important. A couple of my clients also bring their favorite storybook, whatever works. So-and-so comes to their dentist, and we have to kind of play through the book while we're working on some of my 20-year-old clients, because their chronological age may be 20, but their functional age may be 3.
Right.
So the other thing that I tend to use quite often is we have blankets available because we have laundry, but I also love to use the lead apron that I put on for radiographs, because it's much like a weighted blanket. And you will see people who have anxiety, or their bodily restraint is beneficial. You can just see them sink into the chair and become more relaxed. And of course, once they're more relaxed, so are you as the care provider, right? So that's important. Some come in and they're very claustrophobic, and being locked into an operatory can be very overwhelming. So we have a couple of operatories that we can unlatch the door, and just for them to know that the door is unlatched, that allows them the mental ability to feel that they could escape, and the first couple of times that I've seen people and had to gain trust, sometimes it's had to be in a car, on a picnic table, outside the front of the office, just to sort of start to build a relationship. And so we have to develop these types of relationships slowly and carefully, so that then we can get to really helping them with their oral health.
Yeah, those are fantastic tips. I mean, those are really great tips. And I presume you agree, Mohit. Now, I mean, we've talked now a bit about what are the different special needs, but I think it would also be interesting to see how is it actually with the oral health status of those patients that we treat. How big is the issue? And I know, Mohit, you did some research and you published a few papers on patients with brain injury. Could you maybe share some insights from those papers specifically on the oral health status of patients with brain injury?
Actually, just like 2 or 3 years back, we as a group and I as a team leader, that to work in this hospital setting, then you see that there's a problem, and then you need to find a solution for that. So the easy solution is, okay, go and give a better oral care. That's the immediate solution. But for the long term, when you look on these patients, that okay, is giving an immediate solution enough, or do we need to find the root cause? And this is how we come up with this a plan after talking to different disciplines together, the nurses, the neurologists, and the dysphagia specialists, because we are a kind of a team who are working together in an interdisciplinary approach where everyone complements each other, and then we try to find a solution together. But in order to find an immediate solution, you have a oral care plan. But what we did is that in this particular clinical study, it was a nationwide study. We took almost like 200 patients with a brain injury, having stroke and traumatic brain injury, and then we didn't look on the present clinical outcome. We also wanted to know what's happening in their past. How was their social behavior history? How many times they were visiting dentists a year, or how many times they are brushing their teeth, and smoking habits, and all kind of an adverse habits actually. So we wanted to link all together rather than just looking on the current examinations actually. So we did this a big study, and in which what we saw is that whenever you see a dental problem, you can divide dental problems into two major parts. One is the acute problem, which is okay, what I see in the mouth right now, I treat that. And the second thing is, there are a lot of things which are not visible. Then you need a dental instruments to know that okay, and these things has not happened in a day or a two. It's a chronic effect. It has happened due to your different kind of a lifestyle, your socioeconomic background, and all like that, and that leads to a more bony destruction, and that is called as periodontitis. And this periodontitis does not happen in a day or a two. It's a process of months and years sometimes. So there's a big link actually between both of them. So in this particular study, what we found out is that doing on this 200 patient population is that they have almost 50% of the population had a very acute problems, like having a visible plaque and bleeding on probing. Whenever you touch a probe, you can see there's a bleeding. So that means there's a gum inflammation going on over there. There's a gingivitis. So these are happening because you're hospitalized, and and the longer you stay in the hospital, the things also go sometimes deteriorates. So these are the acute problems that's happening because you're staying in the hospital. But interestingly, what we found out is that it's not only the acute problem; they have a lot of chronic issues actually. And one of the major thing is severe periodontitis. When I say severe, it's a grade 3 kind of a periodontitis, where you have almost three-fourth bone loss around the tooth. So there is almost no structure which is supporting the tooth actually right now. So the gum has gone down, the periodontium has gone down, there is no bone at all which is supporting the tissue. And the fascinating finding, what we found out is that they all come from a comparatively low socioeconomic background. And when I say low socioeconomic background, it's not only about your finances, but your educational background. And these all are like 70s and into the 90 age group of the patient population, and they have just high school graduates. That is one of the things. 64% of the population were smokers or a passive smokers. So this dose dependent history also makes a lot of difference actually, and this is how we saw that this particular oral health problem is not just an acute problem. It's a process that has happened from long time with your lifestyle, and and uh, and a very interesting phenomena. When I said this to my medical fraternity, they were like, "Oh no, you are going a little bit far away." And what I said to them is that periodontitis, it can actually act as a prognostic factor, as a prognostic model, because we saw a lot of similarities between the stroke patient population, the brain injury population, and the periodontitis. So they have almost similar traits because they have the same social backgrounds, they have same biological backgrounds. That means the socioeconomic status is poor, the education background is poor, they have a smoking habits, and a lot of other factors, the environmental factors, and this local autoimmune host response actually, which is that is called in a very systemic populations or the systemic diseases you have. So you have this autoimmune host immune response actually, and those kind of factors are also present in periodontitis. So my idea was that maybe periodontitis can work as a prognostic model. What I mean to say when I say prognostic model is that at the age of 20, 25, do a yearly checkup of each of your population of the whole country. And if you have a periodontitis issue, you should relate that maybe this person can have a stroke in the future or a traumatic brain injury in the future. So this can act as a preventive measure actually. If you have an yearly checkup and if you're aware with that. So what I'm saying is that if you can keep your oral cavity clean, then you can keep your body as well clean. So this all goes hands on hands together actually,
Yeah.
because this all educational things, training and continuing education to the normal population is very important. Sometimes they ignore it. We are having a fast food lifestyle. We are having a very very busy lifestyle, and sometimes we miss all the small important points. So that was a big idea which I pitch in, and no one is buying right now. But my idea is again going back to the basics. That means finding these answers with the science and evidence, and then go back and maybe try this periodontitis as a prognostic model in the future. And
Yeah.
this might work actually. So that's all about that. That's all in the back of the future right now.
Interestingly and intriguing. I mean, you mentioned working together with other disciplines in medicine, doing research in this topic. Besides the paper that we just showed, you also published a paper on this aspect,
Yes.
and you wanted to show this diagram, which really shows this oral systemic link in more details. Could you maybe explain what we're looking at now?
Yeah, actually, this was a one of the interesting findings that we found out because as I said you that the medical fraternity always have this, okay, the oral cavity is just localized and it's just brushing your teeth, but I wanted to see what are the associations with different factors. As I said you, I work with the patients of the brain injury population, and that is stroke and traumatic brain injury, and 50% of this population have a swallowing disorders issue. So whenever they have a swallowing problems, that means the food cannot go to the food from the food pipe to the stomach. So they are having a swallowing issues, and because of that, the food can be aspirated and can reach to lungs actually, which is causing pneumonia. And pneumonia is a big fatal thing actually. So if you see my triangular chart over there, these all are kind of interdependent and interconnected with each other. If you have one issue, then it reaches to the another one, and this complicates and makes patients more into hospitalization. So the prolonged hospitalization is over there. What we found out fascinatingly is that a lot of microbiological studies has also shown that there are microbiota in your lungs, which are very similar to the microbiota you have in the oral cavity. So how does it land in the lungs? So the simple thing is that it is somehow interconnected with each other. If you have a poor oral hygiene, that means you have a lot of oral microbiota in your oral cavity, which are really not good, having a lot of biofilm and all like that. And on top of that, if you have a swallowing issue, that means the food is not going to the food pipe, but it's entering into the lungs. And those poor oral microbiota, can actually cause pneumonia. So it looks very simple. Okay, brush your teeth, but the connection is quite deeper and quite serious. And it's just not about the pneumonia, the aging population again. As we get elder, our muscle weakness are there. We cannot chew properly. We have a mastication issue. We have a swallowing issues. So we are trying to find a compensatory mechanism. So whenever we sit at home with our elderlies, we see that okay, they are raising their heads just to swallow. It looks pretty normal to us, but it is not normal because the muscle weakness is there. The masticatory weakness is there. They are taking a longer time to chew the food. So they have a orofacial dysfunctions. And this is what we saw in this particular paper was that, which was actually, kind of very fascinating for us, that this oral health, which is periodontitis and having the biofilm and the bleeding on probing, they all were connected with the long term of hospitalization. All the patients who had pneumonia had a very poor oral health, and also these patients also had a very cognitive issues and motor issues. So the patients who were better in their oral health, they had a better cognitive issue, they had a better cognitive ability. They can understand, but if they can understand, they can clean their teeth, they can keep it more hygienic. So this is how it is all kind of correlated together. So it's just not only about the oral cavity, but the orofacial stimulations, the orofacial dysfunctions together makes a major role to play.
It's like a vicious cycle, actually, and this is also something that we keep on pushing as a message, that this oral systemic link is so important, and this is just another example again of, emphasizing why that is, why it is the way it is. How do you deal with the oral systemic link, Anna Louise? Do you try
Well,
to leverage it in your daily practice?
yeah, well, my job is to be aware of the wonderful research that is coming out, and then to educate my patients on it, and then choose to whatever aids and efforts would then benefit them to definitely make improvements on their overall health through their oral health and through educating. Health promotion is a big part of my job, and knowing what's available in local stores, having pictures, knowing the products that are available will help us succeed making a personalized program for all of our patients that we see. Understanding about oral dryness and swallowing and all these adjunctive things. Like there are so many. With each individual person, you need to be following that person-centered care approach and really evaluating every time you see them, and what little steps can you take to improve everything.
Yeah. I see we only have about like 1 or 2 minutes left, and we had actually planned so much more to talk about, but we are already running out of time, which is a nightmare. But I would like to touch upon one thing that we haven't mentioned yet, because I assume it must be so rewarding for both of you to be working with those patients with special needs.
Certainly.
But I think you probably also inevitably experience these setbacks. How do you deal with those? I think tips how to deal with setbacks would be very useful for clinicians who are watching right now. How do you deal with those?
Well, for me, I kind of look more to the short-term things. You always want to do the best you can at each appointment, but inevitably that doesn't happen. And that kind of breaks my heart when those appointments happen, when there's been too long an interval, or for some reason they have, they've increased their iron, so they had a lot more stain, or they just weren't, cooperative today. I see clients under various degrees of sedation. I can see them with nothing, with oral plus nitrous, and IV sedation. And not all the time does any of them work. And sometimes you think you're going to try them on oral plus nitrous, and they're just wired differently. So they're more of a hazard then. So sometimes nothing is better. But there are going to be appointments that are comfortable and successful, and then that's great. I can ask my client, like, how was that today, and talk to the caregivers and make sure we are exchanging great information. But understandably, there will be appointments that are not so comfortable and very challenging and exhausting and almost impossible. And it's really hard. It is a challenge to keep in mind that it's just today, and next day will be better. And this is where good documentation is really important, so that I can say, okay, I felt that like the bottom was great, but like the top, they were just too tired, by their tolerance was poor, or the wrong TV show came on, and so we as a team, you and the patient, don't always have the outcome at the end of every appointment. And but it is very challenging. There are some that, for one of my autistic nonverbal clients, one time we took him into a different operatory, and that was a no-go. That didn't go well. So we won't ever do that ever again. And so that we learn, right? And so with every appointment, you're going to learn. Even if it was unsuccessful, then you chalk it up to either today or there was something that set off the appointment. And fortunately, I just try to remember that we at least have, I think, one excellent visit a year with my specialty clients that I see every 3 or 4 months. And when those come around, it, and I'm just beaming. I'm so ecstatic.
Yeah, I think that's important to keep in mind when you're seeing these patients. How about you, Mohit? Do you have some special tips on how to deal with setbacks?
Yes, setbacks are always bad to hear, actually, but this gives you a more motivation to move forward. The kind of a patient population I have is a completely different population. It's most of the patients are comatose patients. They are just being in coma, and their cognition level is so low, they're agitated as well. So I had a very bad experience sometimes whenever I'm going into the mouth, they have really bitten my finger very hard. They're not doing it because they are not aware about it. They're just doing unconsciously, actually.
Yeah, sure.
So I had a lot of traumas in my hand as well. Whenever you enter their mouth, they will just bite it because they're so severely agitated. And you sometimes as a clinician wants to give up. No, this is too difficult patients. But then it comes the next day. And this is how you move forward. We have the bite blocks for those preventive measures. And sometimes this tongue blades that we call as spatula, actually, we use a lot in our practice. The spatula that we just keep on putting into the mouth one by one, and then keep on raising the oral cavity. So you're much safer to play. You have a much better area to look on and move forward with that. So for sure there will come many setbacks together, but we just have to face it and move forward. And as an academician, this actually I like those kind of setbacks, because this agitated patients that clenched my finger, actually, it actually gave me an idea to make some kind of a device for these patients so that you can easily work on that. So that small bit of finger actually gave me one patent out of that. So I'm happy if my patient bites on me.
I like turning this sort of issue or challenge or setback into an opportunity. Actually, I think that's the entrepreneurial mindset maybe that you need.
Yes.
Yeah, that's great. Yeah, as I said, we had listed many more topics that we wanted to discuss, but I'm afraid that this is all the time that we have. So I think we have to say our goodbyes. Thanks in any case to everybody who's joined us today. Of course, a special thank you to the speakers of today, starting with you and Louise. Thanks so much for sharing your expertise, and I mean your experience on this topic is really invaluable. That's a really rare case. So thanks so much, and good luck with everything.
Thank you.
Thank you so much to you as well. Thank you.
Yeah, thank you to you as well, Mohit. I mean, it was a pleasure hearing how you approach the special needs topic, and good luck with all your work at the university and with all the important research that you're doing. I think it's great to see your papers being published. So keep it up, and thanks for joining today.
Thank you.
Yeah, and for those still watching, don't forget to subscribe to our YouTube channel. You can also find us on Twitter and LinkedIn at Sunstar Global, or visit our websites, sunstar.com, the Sunstar Foundation.com, and sunstargam.com. If you missed us last time, you can watch back our conversation on cancer therapy, as well as many other episodes for free. This one as well will be on demand on our YouTube channel. Just go to our Let's Talk Oral Health playlist on our YouTube channel, and you can watch everything back for free. We will now enjoy a small summer break before returning on September the 5th with another episode of Let's Talk Oral Health. The theme will be back to school, because we will discuss home-based oral care from the perspective of pediatric dentistry. So a lot to look forward to, I guess. As always, keep an eye out on the channel. Thank you again, and catch you all next time. Goodbye,
Thank
all.
you. Take care.
Thank you very much. Bye-bye.
Goodbye.